So the topic is sequencing of MCRC. I think Viraj gave a very good background of where to choose what, and let's see if all the panelists agree on that point. Okay, so we have called the panelist. This is my very favorite case report because even though the case started in 2013, 2023, this makes a huge difference. Mr. NKG, 57-year-old male, came to me in 2013 with right-sided MCRC wild type for KRAS only. Later on, it was NRAS wild type also. CT scan, if you see the ascending colon, there is a primary and bilobar liver metastasis are there. This is no brainer, but liver limited disease only. Okay. So this is a very famous even version 1 of 2022 and version 3 as of today also. This is a red box which says that no anti-EGFR in any circumstances could be given for right-sided MCRs. Okay, very, very crystal clear, 2023. Viraj also showed ESMO guidelines, which says if you are using doublet, you can use cetuximab or anti-EGFR. And if you are using triplet, you can use BEV on the right sided. Right, Viraj? That is what you said. Viraj has very crystal clear said that in the first line, right sided, he would not even bother about doing KRAS and RAS. But let's see what the other panelist says. Chetna, do you ever use anti-EGFR in right-sided?
No, actually, I agree with him. I am not using.
You agree with Viraj. Any of the panelists disagree with Viraj? I disagree.
No, so you are talking about first line, right?
I am talking about the first line.
Yeah, I do not use.
In the first line scenario, we are talking right now of liver-limited disease. I would again reframe my question. In a liver-limited disease with conversion therapy or conversion to surgery is the aim, would you use anti-EGFR on the right side?
So no, actually, I am still in liver limited also. I am using BEV, but only thing is I stopped bevacizumab 6 weeks before surgery. Like I give it for first 3 cycles and then in next 2 cycles I won't give. But I'm not using cetuximab in this patient.
You will not use it. Okay, perfect. And if it is left-sided, whether it is liver limited, let me ask Dr. Pandey, if it is left-sided, liver limited, lung limited, or peritoneal disease, would you use anti-EGFR in all 100% of patients if they are RAS wild type?
Not in all patients, but it is definitely one of the treatment options.
So which patients you would not use?
Especially if I'm using a triplet combination, I'll prefer to use BEV with it. If I'm using a doublet combination, I'm okay with cetuximab on the left side tumors.
Okay. So you said that, Viraj, I want you to talk about a deeper study, which has just come in GI 2023. And his wording about if he's using triplet, he will use BEV even on the left side. If he's using doublet, then he would use anti-EGFR. Do you agree with his statement?
So I was using triplet plus anti-EGFR a while back, but this GI ASCO, we had triplet study, which showed that doublet plus anti-EGFR versus triplet plus anti-EGFR is identical. It just adds toxicity. So yes, if there is no cost constraint, all of my patients will go for doublet plus anti-EGFR, period, left side.
Okay. So the deeper trial, I don't have that slide because this is just GI 2023. I didn't have complete access. It says that left-sided MCRC, triplet plus cetuximab, and if it is BRAF and pan-RAS wild type, the PFS is highest as compared to panitumumab, as compared to bevacizumab. It's a phase 2 data but there is 390 patients of this phase 3 data.
So the same results were also seen with Wolfe study, but we have to be careful. These are phase 2 small data. The triplet is a randomized phase 3 data, and which has concluded now that one must not use triplet plus anti-EGFR.
So you would not pay any attention to deeper trial right now.
We will pay attention.
Okay, okay. Dr. Das.
Yes, sir.
Left side, MCRC, RAS wild type, even it is surgery, is the resectability is the option, or peritoneal disease, resectability is not an option. Anti-EGFR plus doublet in all,
No, if it's resectable mets, then I will not use any biologicals.
you would not use any
No,
biological.
not in resectable because they don't help in resectable metastasis.
They don't work.
There are data that in resectable, actually, in fact, adding cetuximab can worsen the outcome. So in resectable metastasis, rather I will give only chemotherapy. So in such
Resectable
situations,
metastasis.
if the response rate is higher, then triplet is okay. Otherwise, triplet or doublet, only PFS benefit. There is no overall survival difference.
There is no overall. Dr. Sachin Jain, you would agree with this statement of Dr. Das?
Yeah, exactly. I'm agree with Dr. Das.
Okay. Any of the panelists who says that chemotherapy backbone alone is enough if we are looking at the resectability principle? Probably I'm reading different textbook.
I think so. You are asking two different questions, sir. What they were answering is if you had a 1 or 2 liver lesion where you don't need a conversion. So in a resectable
No,
MCRC.
I'm talking of liver limited, but upfront not resectable.
Correct. So
The
there, of course, they will
conversion
use.
means upfront unresectable. That is what I mean of
Correct.
conversion.
So there now the answer will change.
So what I was referring, that is upfront resectable. Maybe there are
No. Conversion means unresectable to resectable.
Okay, in such situations, yes, doublet chemotherapy plus anti-EGFR in left-sided tumor, RAS wild type.
And right side?
Right side, I will prefer doublet plus bevacizumab. I
Doublet
don't
plus
use
bevacizumab.
anti-EGFR in right side.
Okay, so this is the paragraph from the famous study CAL-GB, which Viraj also has quoted and which has revolutionized our thought process about bevacizumab as one of the key factor on the right side. So I would read verbatim, the combination of chemotherapy and surgery rendered 140 patients disease-free. Median survival for bevacizumab group was 62.2 months and 64.7 months for cetuximab group. And there is no left-sided or right-sided here. How English knowledge, even though I'm from the Gujarati medium, but English knowledge tells me that if the conversion is successful, irrespective of the sidedness, patients will live longer, whether it is cetuximab or whether it is bevacizumab. इसमें कहाँ लिखा है कि राइट साइड पे सिर्फ बेव देना है और लेफ्ट साइड पे सिर्फ cetuximab देना है? So my point again is, when it is a conversion, our aim is different, and when it is completely unresectable, our aim should be different. Okay, so this is what the two slides which I want to show, that if conversion and successful surgery is going to make patients live longer, would you not select the agent which increases the conversion rate? There are multiple studies, 2010 to 2014, which says that if you use cetuximab, you have a higher conversion rate, which is again as shown here, that if you use cetuximab to chemotherapy in RAS wild type unresectable disease, improved R0 resection rate by 2 to 3 folds. And this is a systematic review of conversion to resectability. 2,900 studies were reviewed, out of which 30 satisfied selection criteria. and maximum conversion rate in FOLFOX, FOLFIRI plus cetuximab arm was 28.6%. Okay, so let me start from sir. Yes,
Probably all of these trials in in cetuximab arm we will took wild type KRAS. So mutated KRAS itself a bad disease.
correct. No, we are right now
cannot-
in
we
this
cannot
panel, we are talking of
Compare
wild type
these
only.
trials such type.
Sorry.
Because in bevacizumab we have took both mutated and
No, right. I'm asking question, and since you have the mic, sir, that RAS wild type, KRAS, NRAS, and for Viraj's benefit, I would say BRAF wild type also. HER2 not amplified also, because otherwise he would add these 2 points of not using anti-EGFR. All are wild type, and conversion or resectability is the only aim. Would you not use anti-EGFR based on this data, even on the right side? See, left side, there is no brainer. Almost all of us would like to use anti-EGFR. On the right side, would you not like to use anti-EGFR?
I think there is a need of trial dedicated to such type of patients. Before this, I will not like to use EGFR in such type.
Okay, perfect. Dr. Chetna?
So as I told you, till now, I have been using BAVE and I stop it. But whatever, I mean, you have shown good, I do not know the answer.
In fact, the deeper trial also, it's a very interesting. I'm waiting for the full paper, and I don't think, Viraj, there is full paper right now, right? Okay. So in that, the triplet plus cetuximab, also the conversion rate is also high. Although it is still a PFS data, we don't have the OS data.
So triplet, you are saying triplet plus cetuximab.
Triplet plus, that is a deeper trial, the triplet plus cetuximab versus BEV. Dr. Surinder Beniwal. You are the Dr. Surinder. I'm sorry. Dr. Satyanarayan, you have not spoken so far. What, based on the data, based on the discussion right now, if resectability is better, and CalGB also showed that right or left doesn't matter, would you not tempted to use anti-EGFR, because you do not have to stop, you do not have to worry. The mortality with BEV is little higher compared to mortality with cetuximab or panitumumab. Would you not tempted to use anti-EGFR if the resectability is only an issue?
I will not use.
You will not use. Okay, perfect. And what is the reason for that?
Till the data is not in favor of anti-EGFR, it will be right-sided.
So these are the slides which are all the papers and review articles. This is not something which I have made up any of these. CalGB studies also said that right and left side may, if you use and if there is a resectability, they live beyond 65 months. You have all the data in the world.
Sir, not any either NCCN guideline or various guidelines.
So NCCN guideline is the root cause of all the issue. I agree. And I also follow that. That is perfectly fine. Okay. So our patient in 2013, we started on
But
FOLFOX.
can I make a comment here?
Yes,
I think
please.
so the message has to be clear. Although NCCN says no, ESMO categorically says if you're shooting for a response and going for conversion, doublet plus anti-EGFR makes sense. I have used it. I'm not saying I have not used it. I have used it in right-sided when I wanted to convert desperately, and we have managed successfully. But we have to be very careful. That you can use is a good message. You should use is a difficult message. You remember our can and should
You can use,
discussion.
yes. No, my point is that in the right side, in the panelist mind, anti-EGFR is not surfacing. Okay.
Sir, may I make one
Yeah,
comment?
please.
Sir, probably you are referring that resectability conversion of unresectable to resectable is a good surrogate marker of good survival.
Correct,
Okay.
absolutely.
Okay. So when the pooled analysis of CalGB and other trial, they prove that the bevacizumab survival is better on right side compared to cetuximab. So that means that factor, resectability, that was already taken into account. And after that only, it translated into overall survival. So even after that higher conversion of unresectable to resectable, it translated to a overall survival benefit on the right side. How will you explain that,
Okay,
sir?
so you spoke about CalGB. So this is the reality of CalGB, based on which we have started and changed. 2005 to 2012, the trial was going on. 2010, 5 years after starting CalGB, the ARAS mutation concept came in the picture. 2015, the trial follow-up was over. 2017, the publication and practice changed overnight. Even till now, people are following that. In addition, only 250 patients in each arm were KRAS wild type. Conclusion, out of 250, when it was 1,700, 900 patients, is it really justified? CalGB, in my mind, it was a good opening trial that yes, this and this is better. But I think what I'm trying to say is that, again, it's a choice, it's an option. I'm trying to say is that don't get blinded by NCCN guideline. Just because NCCN says that by only left side means you have to just stop using that drug. Do not be blinded. Use your own data, use your own head, use your own. See, this is the CalGB reality. And this is not something which I have taken it from the review article where there was a criticism of CalGB. Okay. So what Viraj said, the message is loud and clear. I think Viraj and I, both of us agree. If any of the audience have any issue, they can raise the question. But what we believe is in the right-sided, when the conversion is the aim, anti-EGFR remains an option. Okay, that is what we wanted to say. Let's move forward. Folfox plus cetuximab. Yes, Sachin.
Comment about the new which had combined that with Folfox, and you showed that in operable or borderline operable, the addition of cetuximab was inferior.
Right. In the borderline, addition of cetuximab was inferior.
Yeah, that was I referring in my earlier statement that in resectable setting, use of biologicals actually.
So we are coming to that. So continuation of biological in a resectable patients, and it's our honor, Badwe sir has just come. Good afternoon, sir. So our patients, we started on Folfox plus cetuximab, 4 cycles later, good response, still unresectable, 8 cycles unresectable, 12 cycles later. It was almost now that any surgeon could resect. And the surgery was done. I have written in the pink for the want of time. I would say it was R0 stroke R1 resection. So assuming it is an R0 resection, let's start from Dr. Sachin Jain. You see, for today's scenario, left-sided unresectable liver-limited disease, you gave doublet plus cetuximab. At the end of some chemotherapy, you could achieve R0 resection. Would you continue biologic or would you continue only chemotherapy?
I will continue biologic only.
You would continue only biologic?
Only biologic.
Okay. And this is based on which data?
As we are saying in the right side already.
No, let's talk of left side because right-sided, many of you don't want to give anti-EGFR. So let's talk of left-sided.
For the side effects related to that, I would like to continue cetuximab alone.
Cetuximab alone, okay. Dr. Surendra Beniwal, you would like to continue only chemo, only biologic, or combination of both?
Has already taken 8 cycles of chemo.
Patient has taken, say, 8 cycles of chemo plus Folfox plus cetuximab.
We have to complete chemotherapy of 6 months and then we have to continue on.
Then we have to continue cetuximab. Okay. Chetna?
I'll continue the patient on chemotherapy.
Continue the patient on chemotherapy. So NCCN guideline lovers, it clearly says that systemic therapy is compulsory to complete the 6 months, plus minus biologic therapy, and it is category 2B for biologic therapy. So let me jump to Dr. Viraj now. Viraj, what would you do in your practice?
Complete 6 months of perioperative chemotherapy and not give biologic after operation.
not give biologic after operation. Okay. Anyone?
It's R0 operation.
Suppose, so there was a very difficult surgery. They did RFA on liver, they did metastatectomy, they did segmentectomy. I spoke to the surgeon. Surgeon said, Amish, take with a pinch of salt that it's an R0 resection. Okay. Now what would you do? Because a real case, I have treated this case for last
Right.
10 years.
So I would trust our surgeon. We would trust our surgeons. But the days are not far when we'll have ctDNA. If ctDNA is positive, that means it's positive. Then I'll give
Okay.
biologic.
And
I
Dr.
think so
Jain,
our practice
Dr.
will
Jain, if
happen that way.
ChatGPT says that continue biologic and don't give chemotherapy, what would you do? You don't need to answer. We are not ready for that. Biologic, I don't think in R0 resection, continuing biologic has got any data on survival. If any in the audience is aware of any of the data, so I think what Viraj has said is very crystal clear consensus that if you have achieved R0 resection and you trust your surgeon, then continuing biologic does not make any sense and there is just no data. So I don't think that it should be continued of that biologic. Okay. So this was the major trial based on which the NCCN guideline changed. Please remember this trial was almost 99% patients were USA patients. Okay. There were no other patients outside USA here. Okay. So now let's talk of another point. We have 5 minutes. So all the trials which I have listed, so now we are talking of unresectable, ever unresectable disease. Okay. Patients is never going to get operated, peritoneal disease, Barber ke liver, bilobar disease. All the trials are here. And these trials, PFS, if you focus, is almost the same. But then go to OS. OS is different. Dr. Pandey, what does this slide tell you? PFS is almost same, but OS is hugely different.
Yeah, so this patient, most of the patients went on receiving second, third, and fourth line subsequent
Correct,
treatment.
absolutely. So do you think that OS is sort of, taken care of because of the second line and third line?
Yes, definitely
Okay.
second and third line.
Any other thought any of the panelists have? See, one thing is very crystal clear. Those who have received anti-EGFR and they progress, we are going to give them BEV in clinical practice. Am I right? Those who progress on BEV and then those who progress on BEV, either you continue BEV because there is some data of that, or you give anti-EGFR, as Randeep also mentioned in his question, right? Yes, Dr. Pandey.
Yeah, so basically sequential therapy with all the active agents has to be given to the patient at some point of time in the second or third, fourth line
Absolutely
to
right.
improve the overall outcome.
Absolutely. You have made my day. So now let's look at this meta-analysis. There are in fact 3 meta-analyses. I have taken these 2 meta-analysis, Khatak meta-analysis and Lee meta-analysis. And it says that the right sequence or the sequence of anti-EGFR followed by anti-VEGF is better than anti-VEGF followed by anti-EGFR. All the 3 meta-analysis says that. Okay. So now let me go back on this. Based on these meta-analysis, based on this PFS, does it not make sense to start with anti-EGFR in our patients? Again, I'm talking of left-sided, right-sided conversibility is out. Now we are talking of peritoneal disease who are never going to be resected. So does this slide and does this meta-analysis and the trials of paradigm study, which is only left-sided, do you think that starting with anti-EGFR in almost all patients on the left-sided wild type makes sense? Okay. Anybody, I will complete in my time. Anybody else has any other? Yes, Chetna.
So theoretically, yes, we would like to do that, but it causes a lot of financial toxicity on the patients. Very frankly, Amish, it is very, very difficult to give anti-EGFR to the patients. BEV is easier because cost wise, there's a lot of difference.
Okay, so you are talking only cost wise.
Yes, yes, I mean,
Yes, Viraj.
Next month, it will be same cost as BEV.
sorry.
From next month, it will be the same.
Ah,
We don't know. We don't
So-
know. As in, they have
so-
not declared the
sorry.
cost.
Oh, sorry.
He has to explain
Oh,
one-
sorry.
Okay.
Only.
If anybody in the audience has any question, if they don't have question, maybe we can start from him and go. If any of the panelists want to give any comment on what we have spoken. Chetna.
So, in my patients, when I counsel my patients in the left side, I always discuss anti-EGFR and I tell them that this is what I would like to use. But we have an option which is equivalent option of bevacizumab. That's what I generally do. And in my
Wait
experience,
1 minute. So equivalent option means you believe in the left-sided
yes,
anti-EGFR and bevacizumab both are equal.
Uh,
Forget about the
it is
cost.
equivalent, yes.
Left-sided.
it's not much of a difference according to me.
Not much of a difference, Chetna. Amazing. I have to meet you during the lunchtime. Okay. Viraj, you agree that left-sided overall survival, anti-EGFR and anti-VEGF, not much of a difference?
So based on paradigm, she is right. It was only 3 months difference in survival. But there were a lot of problems with paradigms. I strongly believe or endorse anti-EGFR if it's on left side and cost is same as BEV. I don't see any reason why we should not use
Why
it.
we should not use. So,
In left side, I will prefer anti-GFR along with
anti-EGFR, Dr. Pandey.
So anti-EGFR, but we have to take care of oxaliplatin neurotoxicity and stop it after. it
Absolutely
worsens.
right. You are absolutely right.
So I have just a query. Are you doing ctDNA once the patients progress on anti-EGFR?
Not routinely.
Not
Not
routinely.
routinely, right.
So anti-EGFR then followed by Varanasi.
Viraj, the last comment on the continuum of care on the right and left side both, if you can summarize.
So if it's how I treat left-sided colon cancer, first line would be doublet plus anti-EGFR, second line would be another doublet plus BEV, and third line would be ctDNA. If RAS is still wild type, re-challenge with anti-EGFR. If RAS is mutated, go with anything TAS, BEV, or regorafenib. Now on the right side, I typically use 9 out of 10 times triplet plus BEV. I do use doublet plus anti-EGFR when we want to shrink those liver lesions and go for operation. But otherwise, for simplicity, let's go for chemo plus BEV, second line, another chemo plus BEV based on TML and E3200. And third line, Dr. Randeep Singh asked, the data is very flimsy, CO17, but we do use anti-EGFR in third line. But yeah, that is how I would treat.